Good afternoon. My talk is on UBE lateral position. I would like to space my talk under the following headings, starting with a briefing on the issues faced with prone positioning, then on a short intro on lateral positioning, a video demo of the same, followed by its advantages and disadvantages, and a short summary. UBE, as we know, is a novel, minimally invasive spine endoscopic technique. Can be used to treat a variety of spine pathologies ranging from discectomy, decompression, and fusion. UBE is classically performed with the patient positioned prone with abdomen free on a radial frame. As we all know, majority of the problem caused by prone position is due to pressure on the anterior structures, resulting in pressure sores, post-operative vision loss, resulting from inappropriate orbital pressure, lateral femoral cutaneous nerve neuropathy, intraoperative pressure, inappropriate pressure on vital structures of the abdomen, resulting in ischemia and organ failure, cardiovascular changes, cardiac arrest, issue with providing airway management, and CPR issues as access to anterior structures is limited. If you look into the literature dating from 2020, some of the major complications reported with prone positioning are post-op vision loss, facial pressure sores, cardiovascular risk, ischemic orbital complications, hypovolemia, cardiovascular collapse, deep vein thrombosis, abdominal compartment syndrome, increased bleeding, rhabdomyolysis, cardiac arrest, air embolism. A simple alternative to prone positioning for endoscopic spine surgery is lateral positioning. Here, the patient is placed in a side-lying position on the operating table with aid of two longitudinal bolsters used to maintain the position. Now, let's look into a short video demo of the procedure. This is a case of 53-year-old male with right-sided radiculopathy with MRI showing right paracentric disc protrusion at L4, L5 level. Patient is positioned in left lateral position for the right-sided disc. If it was a right-sided pathology, we will have to place the patient in left lateral position, right lateral position. Under CM guidance, midline medial pedicular line is marked. On lateral projection, walking forward is created in line with the lower entry. Uniportal is created 3 cm cranial to the working portal. Initially, the working space is created with the aid of blunt osteotome. With the aid of RF probe, spinal lamella junction is and inferior articular course of L4 is delineated. Levels reconfirmed. With probe, confirm bony landmark, and a small dent is made in the labellar flavor. Flavotomy is done with Gerson punch. Once adequate flavotomy is done, this material is extruded out and discectomy is carefully completed with the aid of disc punch. This is the final disc material removed. Now let's discuss the advantages and disadvantages. First, advantages. Easier position. It's easy to position the patient. Lesser bleeding as there is less intra-abdominal pressure. Hemodynamically, it's better for the patient and for the doctor. The access to an airway is maintained at all the times, thus any tooth problem can be corrected quickly. Procedure can be done even with a surgeon in a sitting position. Wider interlaminar space is there, so the body, less body work is needed, and also in case of pregnancy, this can come handy. Another one significant advantages of lateral positioning is that when you are dealing with the right-sided pathology, for beginners in UBE, operating from the right side with instrument on your left hand can be quite challenging. But in left lateral position, as the right side is up, instrument will be on your right hand and the procedure can be carried out easily. Coming to disadvantages, the surgeon should be familiarized with operating techniques in lateral position. There will be a short learning curve for surgeons not accustomed in operating in lateral position. Major risks arise from compression on neurovascular structure, including brachioplexus injury, ulnar nerve, and common peroneal nerve neuropathies. Poor circulation on dependent nerve. So let's quickly summarize. Pros: lateral positioning usually can be can help negate many of the common complications associated with prone positioning, especially in vulnerable populations. It is easily implementable, allows for free abdominal movements in obese and in pregnant patients. Positioning can be achieved with minimal manpower. But decompression or fusion in lateral position hasn't been tried yet. There is lack of literature regarding the advantages of this positioning, and a lot more cases has to be done, and studies has to come out to assess if the positioning has any true benefit. Lateral positioning in unilateral bipolar endoscopy can be kept as a valuable tool in the armamentarium for special cases, especially obese and pregnant ladies, but requires surgeons who are willing to experiment and to understand all its advantages and disadvantages. Thanking all of you for patient listening. Thanking organizers for this wonderful opportunity. Thank you.